Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
I will be talking about some key studies from ID Week, which occurred last week in Washington, D.C. I have no disclosures, a disclaimer, and we will be first talking about the preliminary results from the Hep B vaccination with Hep B CpG, or known as Heplisave, and this is preliminary results from the BEe-HIVe randomized controlled trial in persons with HIV. Next, I'll take us through kind of briefly 3 oral abstracts regarding real-world outcomes using injectable cabotegravir-rilpivirine. And then last, if time allows, although I know that this isn't something that a lot of people are going to be doing, I did want to just highlight this potential advancement in the treatment of histoplasmosis, an opportunistic infection that I think is pretty prevalent worldwide, about using single-dose liposomal amphotericin B for that. So let's first talk about the BEe-HIVe results. So as for background, as most of us know, Hep B vaccination seroprotection rates in people with HIV are significantly lower, ranging anywhere from 18 to 71%, than in adults without HIV, ranging anywhere from 60 to 80%. The Hep B CpG vaccine, otherwise known as Heplisave B, is a 2-dose series that is dosed 4 weeks apart for adults greater than 18, which was FDA approved in 2017. I will be referring to it as the Hep B CpG vaccine, and that comes from the fact that it's a cytosine with a phosphate and guanine, and that actually binds to a toll-like receptor number 9, which elicits a sort of immune response that is meant to sort of create more B and T cells. And so it is not therefore surprising that in immunocompetent adults, the seroprotection rates with older Hep B vaccines, such as Engerix or Recombavax, ranged from 65 to 80%, whereas with Hep B CpG, it ranged from 90 to 95%. And the big thing with that is that there hasn't been much data in people with HIV regarding the Hep B CpG vaccine. We do have results from a single center study, which I know have been reviewed before in ECHO, of 51 persons with HIV without prior immunity to hepatitis B receiving Hep B CpG demonstrated overall seroprotection rates of 82%, with higher SPR in those with higher CD4 cell counts. And I think all of us have been waiting for BEe-HIVe results. As a reminder, the BEe-HIVe study, or CTG 5379, is an ongoing prospective phase 3 open-label randomized control trial with the goal to evaluate the safety and immunogenicity of Hep B CpG in adults 18 to 70 years of age. In the far left, you'll see who was in the study. So persons with HIV aged 18 to 70 who had been on a HIV treatment for at least 56 days with a negative Hep B surface antibody and no history of prior hepatitis B, whose CD4 cell counts were greater than 100, HIV RNA levels less than 1,000, not pregnant, and if they had diabetes, had to have an A1C less than 9%. There are 2 arms to the BEe-HIVe study. The first one is Arm A with 561 people, and it's still enrolling. And those are individuals who were previously vaccinated but had no antibody response, or what we'll sometimes refer to as non-responders. And they are being randomized to Engerix and Heplisave. Arm B, of which there's 73 individuals, are those who are never vaccinated and it's just a single arm study, and they are being given the Hep B CpG vaccine. So those are the results that we have, Arm B results, again, in individuals who are Hep B naive. And their objectives in this arm are to determine 28-week seroprotection rates, which they defined as a Hep B surface antibody greater than 10 of a 3-dose regimen, 3 doses, in Hep B vaccine naive persons with HIV, and to describe greater than 3 adverse events. And I'm just going to pause for a second because I just said that it's a 2-dose vaccine series, and that is indeed what most of us do and give. I recently learned that in individuals with CKD, or chronic kidney disease, there might be some recommendations to give a 3-dose series. And in this study, they did a 3-dose regimen. So what they did was give Hep B CpG at entry 4 weeks and 24 weeks, and then followed them for 72 weeks. This is an image from their PowerPoint sort of talking about when they gave the vaccine, followed by when they sort of monitored. These are some patient characteristics. These red squares are not from me, but rather from the PowerPoint of the abstract. And I think just to highlight that it had individuals with a sort of median age of 47. They wanted to highlight that there was a pretty good representation from those who were female assigned at birth, and had 66% of individuals were Asian. The other sort of patient baseline demographics are in this sort of table, and then on the right are baseline HIV-related characteristics, where the median CD4 count they're drawing your attention to is 625. Why is that worth highlighting? Well, we know that there are some sort of factors that are associated with lack of seroprotection in persons with HIV, and I think most of us know that oftentimes having a lower CD4 count, having viremia, and also actually having concurrent hep C infection are related to or associated with sort of the not getting as immunogenic a response. And so this study had people who had relatively high CD4 cell counts. This is an image, and I'll talk through this on the next slide, of the serum protection rates and their results by study week. On the y-axis, we have the percentage of participants, and then here on the x-axis in this bold, you'll see the serum protection rates in percent across these different study points. The things I'd like to highlight are the light blue, which means that your surface antibody was between 10 to 1,000, and then greater than 1,000 is in the darker blue. And you can see that really starting at about week 8, we start seeing the sort of ideal, in my opinion, goal range. And I'm not saying that you can't have greater than 1,000, but I at least want to see someone whose surface antibody is greater than 10. And so we'll start seeing that here. The other thing I'd like to point out is that we do have these seroprotection rates from individuals who have only received 2 doses, right? So as you might recall, those individuals who received 2 doses, I bring that up because that's what most of us have been doing with this vaccine, is giving it at entry and then week 4. And luckily we have some information before the third dose was given that seroprotection rates are quite high. And so that was the image now just in text form of 74 people with HIV in Arm B. 68 completed the 3-dose series. In fact, 74 completed the 3-dose series, but they didn't have hep B surface antibodies on those remaining 6 just because of timing. And of those 68, 100% achieved goal seroprotection, and 88% actually had a very high surface antibody. As I already mentioned, seroprotection rates were also evaluated after the second dose of hep B CpG vaccine. 94 achieved SPR 8 weeks after the second dose, or 94% rather, and 98% achieved seroprotection rates 24 weeks after the second dose. So they also wanted to talk about adverse effects. As you might recall, that was their second objective. This was well tolerated. 61% of participants experienced 1 or more adverse effect related to study participants. And you'll see that the vast majority of people said that they had a grade 1 or 2 adverse effect, and only 1% had a grade 3 adverse effect. And here are the percentage of participants who experienced whatever these symptoms were. And you'll see the vast majority of people had an injection site reaction of 40%. They don't go into some more detail regarding that. And then some people felt tired. In general, when I have been giving this, I've noticed that people do quite well. And I have not heard of patients haven't shared any potential side effects they had after the hep B vaccine, whether it be the older hep B vaccine or the new one. So in summary, in this single-arm study, again, of Arm B of the BEe-HIVe randomized controlled trial, 100% of 68 persons who were hep B vaccine naive after the 3-dose hep B CpG achieved seroprotection, which they defined here again as a surface antibody greater than 10. There were no unexpected safety issues or deaths. In this study, there was low representation from predictors of non-response, again, low CD4, HIV, viremia, hep C. And however, Arm A will have individuals with lower CD4 counts just because it's a bigger patient population. And then I think the big thing for me, and we can talk about this after, is that unfortunately the 2-dose hep B CpG vaccine sort of schedule was not the protocol used in this study. I was very disappointed to hear that. I think I had kind of just missed this, Arm B was going to be doing a 3-dose series as opposed to a 2-dose series. And based on what I've seen, and I don't know how the OI guidelines will change based on these results, but I am disappointed that it was a 3-dose series that was used in this study protocol. That being said, we do have some data that after 2 doses, there was pretty darn good seroprotection that mirrored the initial data we have about this hepatitis B vaccine in immunocompetent individuals. So that was prelim results there. Next, I'd like to talk about some real-world outcomes with long-acting injectable CAB-RPV. And I will not do all of the abstracts regarding long-acting CAB-RIL justice because there were many at the conference, but I have decided to highlight 3 of them here. One is looking at real-world use and effectiveness in the U.S. in the first year after rollout. The second one, which was a retrospective study looking at low-level hep B viremia in individuals who had an isolated hep B core antibody. And then the last is a nice acronym that is the CARISEL study, which is implementation effectiveness in EU or European Union clinical sites. So the first one, again, we're just one slide per each of these oral abstracts. So I just wanted to give you guys a taste of what was discussed. The first one was actually among the OPERA cohort, which we've talked about before, which is a cohort of approximately 145,000 persons with HIV in 96 clinics in the US. And of those in the OPERA cohort, 383 treatment-experienced persons with HIV had received their first dose of IM CAB-RPV between January 2021 and February 2022. As far as some background characteristics of those individuals, the vast majority had a viral load that was undetectable. 7% had a viral load that was technically suppressed, less than 200. 7% had a viral load that was greater than 200, and 2% had no baseline viral load. 89% of individuals remained on therapy during the study period, and of those, 95% of those who were undetectable at baseline remained undetectable. And then 91% who were viremic at initiation, there were 21 individuals, achieved viral suppression. And I bring that up because I know that Brian spoke about some of the studies regarding CAB-RPV last week, and so this just kind of adds to that knowledge. The other thing that I thought was helpful for those of us who are implementing this in clinic is that when they were looking at this retrospectively, they found that it was difficult to determine who got oral CAB-RPV because there are different ways to bridge and also different ways to lead in, and because there was poor documentation of this in the EHR, right? Because we know that the PO CAB-RIL comes directly from industry or from the pharmaceutical company, this has been an issue. And so I will be coming back to clinic with that info and sort of trying to figure out ways to make sure that we are doing this as best as possible so people know what prescriptions people have. Next is the other oral abstract, which is about low-level hep B viremia. This was a retrospective case series of about 150 persons with HIV at UC San Diego who switched to long-acting injectable CAB-RIL. They looked back and found that about a quarter of them had an isolated hep B core antibody that was positive. And of those individuals, 3 of them developed low-level hep B viremia, the clinical significance of which is unknown. And here I've taken a screenshot of them describing those patients. I just wanted to highlight, so a couple of things. First patient had a surface antibody that did not sort of confer immunity to hepatitis B, though they had a DNA that was undetectable. And the person was on this regimen of Odefsey and dolutegravir. And then here you'll see that they had a hep B viral load of 95, after which they were switched to BIC-TAF FTC. Patient B was core antibody positive only, and it sounds like there's no vaccination history or surface antibody available, who developed a viral load of 101. And then this last patient was on a kind of a robust regimen of COVID-boosted darunavir and BIC-TAF FTC with a surface antibody that was positive, and they developed a viral load of 14. And the reason why I think they bring up that the clinical significance of this is unknown is that these are relatively low levels. And so I think the authors posited or requested that the pharmaceutical company kind of look back at Atlas and FLAIR and kind of see, do we have any of this data from their stored blood samples? And then the last of the oral abstracts is the CARISEL, which was implementation of long-acting injectable CAB-RIL in the EU. This was actually a sponsored phase 3B multi-center open-label implementation effectiveness trial examining different strategies to support implementation across 5 European Union countries of 437 participants at 18 clinical sites with 70 staff providers. And what they did was they compared a standard arm to an enhanced implementation arm. The standard arm they got education resources, got training on how to give the injection and regular support that was available to the clinics. And the enhanced arm had more face-to-face training, quality improvement projects where they would do like PDSA cycles with the Plan, Do, Study, Act cycle and extra resources. So a very much more intensive support system and implementation system in that clinic. And their month 12 endpoints were looked at viral suppression. That was 87% across both arms. And their sort of conclusion was that regardless of implementation support and clinical infrastructure, that long-acting CAB-RIL can be highly effective for a wide variety of persons with HIV. They, at HIV Glasgow, which actually already happened, but I don't know the results, just happened on Sunday through, I think, Tuesday, shared some more qualitative information about this. So I just wanted to highlight this because I know that implementation has been tricky for all of us. And so it's just nice to know that at the end, that viral suppression was the same across both arms. And last, we just have a couple minutes and we will go through this really quickly, but about histoplasmosis. As you all may know, it's a fungal infection caused by the sort of Histoplasma capsulatum fungus that's endemic to Central and South Central US and Latin America. And persons with HIV with low CD4 counts have an increased risk of dissemination. Here is a screenshot from the National HIV Curriculum of our recommended treatment options in the US, which is to use liposomal amphotericin B 3 mg per kg daily for at least 2 weeks until the patient's clinically improved, and then switch to oral itraconazole. This is an issue because getting amphotericin, especially the liposomal version, is difficult. This is a long treatment course and it's oftentimes not readily accessible, especially in places that need it most. And you may have heard about the Ambition trial, which actually demonstrated that a one-time high dose of liposomal amphotericin B was non-inferior to 2 weeks induction with amphotericin B, the sort of older version that has more toxicity. This was in the treatment of cryptococcal meningitis. So I just wanted to bring that highlight that we're maybe hopefully going to be seeing some higher dose, single dose liposomal amphotericin B injections. This is the method of their study of these individuals with disseminated histo phase 2 study, and they looked at it being given once, it being given on day 1, and then a lower dose on day 3, and then their standard of care. This, again, will be a resource for you, but I'm moving along in the interest of time. Their primary endpoint was a clinical response at day 14, which they defined as resolution of fever and signs and symptoms attributable to histo. These are their clinical findings. This is a screenshot from their PowerPoint, which I think is helpful from a learning perspective of the ways in which people may present and the lab abnormalities with which they may present, and also how this was diagnosed. Most people had a urine histoantigen. They brought this up because this is a study in Brazil that this is actually not available for individuals outside of the study. And so most people in Brazil are getting a histodiagnosis by culture. The results are as follows, that this was a group that was sort of well matched between the arms with a median CD4 count of 25, and that percentage rates were sort of semi-similar as far as clinical response, and there was no difference in absolute risk reduction, and that there were similar toxicities across the arms. And they looked at the end of 1 year at the cumulative probability of survival, and arm 3 versus arm 2 and arm 1, they found was kind of there was no statistically significant difference. So in this prospective randomized phase 2 open label study of liposomal amphotericin induction options for disseminated histo, single high dose ambisome was non-inferior to standard of care for clinical response at day 14. Toxicities were similar, and I think the reason why this is important is that a phase 3 trial is being planned, and I think that has the potential to revolutionize treatment and access to it for persons with HIV globally with disseminated histoplasmosis.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.